So first of all, to start pain clinic, what will you require? Okay. So the requirements are mainly two types. One is the infrastructural requirement and another is the legal requirement. So what are the infrastructural requirements required? I am just talking about India because in this part I'll be mostly discussing on India because here we require few things to start a pain clinic. How to start a pain clinic? Okay, because there are a lot of small topics and small requirements. So we'll be first discussing on those parts. What is the requirements? Especially I am taking in India because we I do not know what are the exact rules in other countries and that might differ. To start, you require some infrastructural requirement and some legal requirement. And among those infrastructural requirement, this is as per our state West Bengal. So there we require these things as a license. But Caroline is there. So in her country, everything might be different. Okay. So overall framework in all over the world is almost the same. Here there are three types of clinics you can register. Either you can register as a daycare clinic, and most of the pain practice is mostly run on the office-based clinics, except for few procedures. Even my clinic is an office-based clinic, and it's for few procedures like I am telling which procedures I have to take, like spinal cord stimulation, that I have to take in Fortis. I am connected with Fortis, so I take there. And rest like vertebroplasty, I take in Fortis. Trigeminal neuralgia, I take in Fortis, but sometimes I do in clinic as well. These are the basic things that some cases needs which are more invasive that we take in the proper OTs. But most of the procedures like the ultrasound, in ultrasound guided most of the procedures we do in our office-based setup. So you should have to first declare as a clinic you want to have an office-based setup or a hospital-like setup. So basic difference is the stay of the patient, but with that a lot of changes occurs. Like the fire license will be different, all the licenses and legal requirements will be different. Now, the minimal requirement is with the clinic with only consultation facilities. In fact, if you see the judgments previously given by the different courts that actually require almost nothing. Okay, except for a trade license, you will require almost nothing. Now coming to the clinic with short stay, that is also known as the daycare clinic, clinic with diagnostic facilities, that is also comes in the same type of daycare clinic. They are not different, but they comes under the same clinical establishment license. Like ultrasound, I can keep in my clinic, that I can use in both the purposes, either diagnostic or therapeutic. But here, at least in India, we have to declare whether this clinic is a monoclinic, that means as a doctor, only sole doctor will be practicing, or multiple doctors will be practicing, that you have to declare. And depending on that, license and other requirements changes. Now coming to the facilities. These facilities are requirement in all over the world. So these are the basic requirements that is required for a pain clinic, even for a smaller pain clinic. Among those facilities, first of all, it's the fluoroscopy. Next, it is the ultrasound and radio frequency. Next, ozone generator. In certain situation, we require a ozone generator and a PRP centrifuge. So these are the basic equipments that you should have to purchase at the beginning. Next, for the management of the emergencies, you should have a proper setup. That means at least one oxygen cylinder. You have to check that whether the oxygen is present or not, and you require an emergency tray. And as an anesthesiologist, we are always properly we require this all the tray. That means they're like the intubation and all of the facilities we usually keep for the emergency management. And we'll require some sterilization equipment. Now, to register your business, you can register under the following heads. But for the trade, we usually prefer the first four one, among which the minimal requirement with the proprietorship, and then it goes to the partnership is the more complicated requirement. Then it comes to the limited liability partnership, then it is coming to the company private limited. So what type of business you want to register, you have to declare. And charity, I'm not discussing because we are not starting the charitable clinic. And in India, these are the minimal space requirement that you should know. But actually, these minimal requirements are too minimum. In fact, it is very difficult to practice for such a small area. But at least we can say it should be at least 300 to 400 square feet. That should be the minimal requirement. Okay. And safe space for everyone. And legal requirements, you will require a trade license. In India, you will require a GST. If you are adding some GST, where the GST is required, like you all know, for the only pain practice, I do not require a GST. But as we are teaching, we require a GST because teaching comes under GST purview, but not the pain practice. So in the practice part, we don't have a GST, but in teaching part, we have a GST. For selling medicine in your clinic, that will require a GST and your PAN number, and these are the common things that will be required. And you will be requiring the pollution board clearance. And usually there are two types of clearance. One, the first requirement is the consent to establish, then consent to operate. These two type of pollution certificates you have to take. You have to take a fire license for your clinic. And again, depending on the type of clinic, whether it's a monoclinic, polyclinic, or it's a night stay patient will be doing or not, depending on that, there are a lot of requirements in the fire sector. Okay. Ultimately, the unfortunate truth is that a lot of bribes happens here. And practically, you have to get hold of someone because if you want to do it by yourself, it is very difficult, at least in India. I do not know. Some person have done it by themselves, but it is not easy. Actually, you have to go multiple times. Next is the clinic license. According to the Clinical Establishment Act 2010, you have to take a clinic license, and that also varies state to state. Because in some certain state, we all the health is a in the concurrent list, means both state and central, they makes their rules. So where the state license and state rule is there, then you can the state can have own clinic establishment like in West Bengal they have the separate rules, and in rest of India there are separate rules. Okay, then you will require PNDT license, and remember PNDT license is very very important because without that it is very difficult because most of the patients we do diagnosis in our clinics. So for that you will require a PNDT license. So who can take a PNDT license? 6 months course that is under government regulation, that is the CBA course, and those who have completed that course and those who have passed that CBAT, that is the competent based examination test, then all the degrees of the practically gynecology, pediatrics, and obstetrics they can take by their name. For us, we have to get hold of it. We usually need a sonologist to keep. Now, regarding there are a lot of uh, institutions they offer a 6 months course, but remember, if it is not a government recognized institution and if you are not passed through the NEET, ideally they cannot take the PNDT license by themselves with the 6 months courses. But as you know, in India license are very lax and sometimes they are not very rigid. So some people, as I know, have taken anywhere, they have done a 6 months course and they have got, but we cannot say anything. But as far as rule is concerned, it should be a government established course, and that will be the only entry point should be the NEET. And in India, there is one thing that is known as the Form F that we do not need to provide every month because we are not scanning on the pregnant patient. So we give a declaration at the beginning that we have to, we are not going to do any procedure on a pregnant patient. So for that, ultimately, we don't have to submit the Form F. But again, this requirement varies state to state. Okay. I am talking about the West Bengal, Odisha, the eastern part of the country. They are comparatively much more lenient because here the female feticide is really, really less. But in areas where the female feticide is more, like Dr. Kanchan from where she is from Rajasthan, from their point of view, their legal requirements regarding the PNDT is much stricter. Okay, and that is quite natural. Now, for the fluoroscopy, we will require a AERB permission for the CM installation. and you have to apply for the TLD batches. So these are all ideal things, but lot of deviation occurs all over the India. Ultimately, you have to maintain whatever is running at your state. Now coming to the practice protocol. First of all, you have to follow all the NMC guidelines. I'm not telling about this because you all know as a doctor what are there in the NMC guideline. Then all the procedures we use the ISSP consent form. The ISSP is the national body who are the regulator or Kansas Society of the Pain Physicians. And we have a specified form of consent. So we usually that is available in the ISSP website and you can get it from there. And usually we put the patient details. Three things we need to change there. One is the patient's name, then the procedure to be performed, and the risks of the procedures. And remember, nowadays, as per the judgment, for each and every patient, you have to write the consent separately. Common consent form, you are filling some portions that is not legal. So for each patient, you have to make a fresh consent form. Nothing to worry. You don't have to print every time. Just put a pre-printed PDF and it's not PDF, docx document file, and there you just change the patient name and the details that we found. Now, in clinic, you have to show the following things. GST number not required unless you are doing a GST related practice. Then PCPNT license and the phonologist license. If you are yourself is a stonologist, then it is fine. Your license and this medical registration and the GST number, not the GST number, clinical establishment license, that is more than enough, along with the PCP entity. And the service list with price, that is ideal. Nowhere it is written, but ideally it should be there in the clinic to open to all to see doctor's name, degree, and timing. Okay. And optional are the patient rights, CCTV sign, toilet sign, etc. etc. Though these are optional, but sometimes this CCTV sign is very important. You should put it. So these are the basic things. I have not gone into the detail because these area, na, state to state, they are different, and it is not very. I think same rule is applied for the all states in India, neither in all countries. So that will differ from you. So if you have done and if you have established your clinic, then you might tell in which state you are and according to which what is required. We can tell about the West Bengal and Rajasthan. So they are like that. Okay. Caroline, what is the situation at your place? What are the legal requirements? Because it is very interesting. What is there in the other states or other countries?
I was thinking about it. Probably
Yes,
most
we
of
require 19 papers to establish a pain clinic. So at your place, how many papers are required?
same protocols. I haven't looked for that particularly, but I guess it's the same and it's very complicated. So this is
Yes,
why most of the doctors go to the hospital. They do everything in the hospital. They don't
yes,
have it elsewhere. Usually this is it in Lebanon.
yes. In India also, it is not that difficult, but here what is happened, there are some agents are there. When we go through them, they actually makes this requirement and the documentation, lot of notary and other things are there. They usually takes this hassle actually.
But the other thing in Lebanon is that now the pain management is something new for anesthesiologists here in
Okay,
Lebanon. So patients go usually to the orthopedic surgeon or general surgeon. We have referred patients much more than our own patients that will who will come to consult us.
okay. It will change because when I started my practice in 2010, it was similar. But now after 14 years, everything has changed. Okay. So with time, when the number of physicians will increase, and then now in India, we have already started the DM pain medicine as a separate branch. Okay, 3 years postdoctorate course. So now the awareness is much more, and now actual patients are coming directly to us. Though some of the referred patients we see, but other patients coming directly to us. Next, move to the next topic, that is the promotion. Again, that is a vague topic because state to state, area to area, everything will be different. But we'll be discussing what are the basic modes of promotion that we are allowed. Remember, in India, as a doctor, our domain is very small. That means we cannot do promotion like any other branches. Okay, like medicine, there are a lot of restrictions of promotion is there. So we'll be discussing in which area we can do the promotion. Right.
Sir, I want to ask something.
Yeah. Okay. Yes. Pritam, you can ask.
Sir, fire license is mandatory, sir, or can...
Yes, fire license is mandatory. To get a clinical license, you first have to submit a fire license. For first 6 months, there is a declaration form. If you give that declaration form, then for first 6 months, they will give you time. And within the 6 months, you will complete all the formalities for the fire license.
Okay, sir.
Okay. And yes, fire license is an area is a little bit difficult because they are these portions not very strict. The rules are very strict. For me, it was much easier because it is in the ground floor. If it goes to the first floor, the complication increases much more.
Okay, sir.
Okay, because the stair size, number of stairs, that becomes a big issue. But if it is in a ground floor, then you have the multiple exits, then it is the easiest to get.
Okay, sir. Thank you.
Okay, so next move to the promotion portion. Okay, these topics I am taking in a very small way because ultimately you have to learn it by yourself. When you will start now, one by one they will come. That when you have started your clinic, but the patients are not coming, so you have to think of promotion like that way. So initially you think something, you start something, but then with time, the time teaches you how to do the things properly. So I'm just saying that the tricks that lot of people will tell you a satisfied patient is the brand ambassador for promoting the service you give. But unfortunately, at the beginning, there will not be any satisfied patient because you are new. And how to get the patients when you are new? That is the most difficult part because once it starts rolling, then things are much easier. So, what we are allowed and what we are not allowed, that is very important. Friends, first of all, we will require a signboard inside and outside the clinic. So instead of multiple signboards, it is better to have a single large signboard with clinic name and in very small your name you can keep because as per restrictions, very large name of the doctor is not allowed. So one board for displaying the clinic name and one board for displaying the doctor's name with qualification, consulting hours, holiday, contact number, etc. Okay. And there are some local regulations. Like in West Bengal, it is 50%. That means 50% you can write in English, 50% you have to write in Bengali. So started if you are in a Hindi speaking country, like a state like Rajasthan, there the requirements will be different. If you are in Karnataka, requirements will be different. Karnataka, I know, there it is 60% will be the local language, 40% is English is allowed. So depending on your local language, so you have to do this signage. Now, we cannot advertise like other things, like Colgate or like Palmolive. We cannot add like that. So how we can do our advertisements? So first of all, this is one of my senior doctor who is a surgeon, a very renowned laparoscopy surgeon. She used to say that your close persons are your promoters. Remember, it is not that at the beginning you have your friends, you have your relatives, you have your neighbors, you have your doctors, you have your local connections, media, merchant association, whatever is close to you, that is actually your first promoter. So, if you want to have an inaugural function, no one can prevent, no rule can prevent to have an inaugural function all these persons whom you know. Okay. It is not that you have to make a very big program, but at least you can call them and you start it at the beginning of your clinic. So that gives you a start. But remember, don't keep any abnormal expectation that this will give from the next day I will start getting patient. It doesn't happen. So you have to be patient on the promotion part. Now coming advert. Matlab, avenues for promotion, what we are having. First of all India radio, FM radio, local TV channels. But these are also similar type. That means once you are established, then they usually will contact you. At the beginning, no one will contact you. So again, if you have any local contact or your personal relation that works here, and All India Radio, I do regular program in All India Radio. But what happens once you start doing now, after 6 months, you will see you are in their name. Lot of presences know you, and ultimately they are calling you. So ultimately, this gives a lot of advantage because it is through that you are propagating your message. It is not that there I am telling my name, but what I am telling is what pain management is, what pain management can do, what is the diagnostic block, how we can treat the pain, what are the do's and don'ts, what are the myths. Depending on the topic, you and presenter usually decide in which topic we want to talk, and then we have a talk show. Sometimes we all also got a phone in shows also that helps us. Now, newspaper boy, okay, because printing a newspaper is a very costly affair. Don't do that. It is possible you can give some pamphlet to the newspaper boy, distribute along with the newspaper. These are very common mode of promotion all over the world, so you can do that easily. But remember, don't keep any unusual expectation. It is not very foolproof, or ROI, return on investment, might not be very high. Return on advertisement spend might not be very high. For the beginning, it is good because these are low cost modalities by which you can increase. Now, souvenir for the local, religious, public functions, they are possible. Again, don't think you will be getting a big ROAS. ROAS, I am taking the term, it is an investment term. That means return on advertisement spend. But they give your name to establish. Then goes to the local magazine. Previously, they were lot of importance, but nowadays their importance is reducing. Then comes to the public awareness programs. Like you have a Durga Puja. In West Bengal, you have Durga Puja. So someone has called in the Durga Puja inaugurations, or some in a program in a school, or residential association meeting, health awareness classes by village, panchayat, local bodies. So they sometimes you can approach, or sometimes your staff can approach to them for those, or you can tie up with the local hospital. If you are doing another hospital, working in a hospital setup, you can take their marketing for you as well. Okay? That I have done many times with the Fortis marketing, with the Genesis marketing for the different hospital. But remember, even from those camps or these residential association programs, you do not expect that you will be getting a very good response with the one single program. What happens? People start knowing you, and you start knowing people, and both are important. And it is not that people will not forget you unless you are not forgetting them. So keep a good relation with so whatsoever person you have a good relation. That is very, very important. Okay. Everything is based on the relation. But one area where ROAS is really high today is the digital marketing. Okay. Especially in cities like Kolkata, Delhi, Bombay, Madras, like all capitals, what is most important is your digital marketing. So in future, I am telling you, there will be only businesses which are tech enabled. Without a digital marketing channel, staying in business for long term, whatever it's a medicine, non-medicine, will be difficult. So you should know the digital marketing basics. That means it is not possible for you. You are not a tech guy that will be knowing all that, but you should have a digital marketing channel. Okay. If you are interested, there are a lot of YouTube videos you can learn by yourself, but learning everything by yourself is not easy. In those cases, you can hire some other person. But as a beginner, if you are having a very small clinic, spending that much of money sometimes becomes difficult. For this, at least from internet, learn few basics. That means how to set up a Google My Business account, how to set up a Bing My Business account, how to set up, create your website. And today, there are a lot of website tools by which you can make your website just like making a PowerPoint presentation. I'm not telling you difficult things. Okay. Like I can just say you one platform, similar platform is like Wix. Okay. So they can give you some platform by which you can just simply by dragging and dropping like the PowerPoint presentation, you can make your own website. Use those tools at the beginning. Okay. If you personally want to know me, you can call me, ask me, so I can share you more data on this. Okay. Because from the beginning time, yes, I do not have anyone to manage my website. My website also managed by myself only. But now when the work increases, there are a lot of integration with the website and your app and a lot of things you have already started, then you have to take hold of the other person. But for the beginning, I think being by yourself is a completely good idea. Okay. And there are two types of marketing. One is the organic, that is what we try. Okay. Even in Google, in for Facebook, we want the organic marketing first. But it takes time. So for the time being, for the bridging the gap, you can have the paid marketing. But remember, though even in paid marketing, ROAS is high. That means you will get more than 10%. I always will get more than 10% of ROAS. More than 100% is also possible. But you can use that tool. Okay. So that is also not difficult. You see the YouTube videos, lot of YouTube videos are there. And by that, at the beginning, you can do it by yourself. And nowadays, mobile apps are also there. It is not that you will require you have to know everything with that. So I have already told that website is very important tool. Now, there are some tools. One tool I have named you, that is the Wix. There are some other tools like the Yahoo My Business. Okay. So similar tools are also present. So with that, you can do your own website. Okay. Now, site should contain about each physician of the practice, list of services, that is very important, and direction to the clinic and fees of the common services. Sometimes fee we do not openly put in the site because there are no regulations on that, but it should be done. And another important part is the search engine optimization. That is very, very important, but for the beginning, it is costly and it is a recurrent process. So you can learn by doing yourself in the small part, but definitely later you have to depend on some digital marketer for that. Okay. So you are just saying you that what are the things that we should know that it needs to be done, because you should know these things I need to do, because as a doctor, we are very weak in this part. First of all, what is meaning by the search engine optimization? That means we have to make our website easy for the search engines to search. So optimize your website. So one thing you should remember, your website should be mobile friendly. That is very, very important. To create high quality content, you can shoot your video, you can shoot the patient video definitely with the consent. Okay. And every patient video, if you are taking, always put the patient content and write the consent you have taken from the patient, because otherwise there will be legal problems. Then you can promote your content on the social media platform. Okay. But in this regard, the new law is coming, but it is not yet came in the India. So till now, we can do this part, but future there will be social media restrictions will come as well. Okay. Now, email marketing, again, it's a tool that is becoming older. Nowadays, email doesn't work as good. Rather, nowadays, what is more important is the WhatsApp marketing. So just remember, there is a platform by which you can get a WhatsApp message, and that is known as the WhatsApp marketing. It is a little bit costly than the other modes, but it is very effective nowadays, because in some countries, definitely, in some countries, WhatsApp is not allowed. So there you cannot have the WhatsApp marketing, but in other areas, WhatsApp marketing is good. Now, use video marketing to attract and retain attention. Repurpose your content with the different formats and channels. That is very important. That means if you are putting something in Instagram or if you are putting something in Facebook, they are different. Their formats are different. So sometimes it becomes nowadays very difficult to do the promotion cross platform, but ultimately you have to do that. So ultimately you have to depend in this part also with your digital marketer colleague. Okay. Now, use analytics tool to measure and improve your traffic website. It's a more complex thing. And again, you need someone for this, and experiment with the different strategies and their results. So before that, it is very, very important. You should list your business with the following business listings like Google. I've already told Google My Business, and Microsoft Bing, then Wow, Yahoo My Business, Baidu. In India, this Baidu and Yandex. Baidu is mostly in China and Yandex is mostly in Russia. But even though when you are doing, we are usually index in all search engines. Now, in the social media marketing, there are a lot of platforms. These are the most prominent platforms. That means YouTube, Facebook, Insta, and WhatsApp nowadays. These are very important tool for social media marketing. Now, coming for the paid marketing, we have the Google Ads for the paid marketing. We have the Facebook book ads. In India, we have the Just Dial, Apollo 24/7. We have the Practo. But remember, the ROAS with the first two is the maximum. ROAS with the Just Dial is minimal. Apollo 24/7 is also minimal, and Practo is also minimal. So I should not ask you to invest on these three things. The above two are much better. And regarding one thing, you should be careful as a beginner that lot of when once you are started your clinic, na, lot of people will come with a lot of proposals and marketing strategies, but ultimately only few marketing strategies are long term. Most of them are bogus. So you should be knowing which marketing strategies are good and which are practically having the no value. Okay, so by that you can grow your clinic from the beginning. So any other queries? Hmm. Yes, sure.
Yes, I have one question.
Yes.
Is there a lot of competition between the clinics because you are making this publicity? How many
You are
clinics do you have?
you are what you are asking?
Yes, and I mean, how many pain clinics there is in your country?
Okay. So India is a very big country. Okay. Unlike other countries, we require a lot of promotion. Okay. What happens because at least in our city, we have around 15 pain clinics. Okay. So that's why I'm telling you right now the situation at your place and at our place is completely different. Okay. It is only one city. And there are multiple pain clinics in every cities of India. So that's why right now pain management is not a very young branches in India. It is a already established branch. Okay. Some may be small, some is related to a hospital. Some there are some clinics which are within a hospital. Okay. That type of clinics are also there. They have a separate name, but they are running within a hospital. Especially the young persons who are starting, they might not have their own clinic. So what they does, they makes a consultation clinic only. All the procedures they tie up with one hospital. So that the consultation they does at one place, and for the procedures they take the patient to other place. So at the beginning, I have also done this. So this is a very common mode of practice. So that's why it is so many clinics happens. Even though whether you have competitor or you don't have a competitor, okay, remember promotion is important because it is not that we are fighting only with the pain management doctors. We are fighting with the. It's not fight actually. It is coexistence. So we are coexisting with the other specialties as well. But what happens nowadays, we got a lot of patients which are referred by different doctors. It is not that you are seeing only my patients or patients by coming by themselves. Okay. Because once you are established and once we have a good rapport with the other doctors, then the doctors himself refers to your patients. Okay. So just 1 minute. Okay. So we don't have much organized topic. So next topic I will be discussing is the examinations. So how you can progress. See, our course is just a basic course. So you have came to know what are the things you need to learn in pain medicine. what are the things you should need to know. The next step is practice. Okay. So if you are working in an anesthesiology setup, along with your hospital, with your anesthesia work, you can start your own clinic. By that way, even in the hospital, you can start or open your clinic and you can start your practice. That is the most important. Now, once you have started, 1 minute, then it will be clear to you, but how you can progress. How you can progress. So, what are the examinations that we can appear after completing 1 year of our practice? Usually, uh, we do 3, 4 examinations for pain management. So I'll be discussing 1, 2 of them. So first of all, it is the FIPP. FIPP started in 2002, so far I can remember, and it is taken by World Institute of Pain. And today, most of the pain physicians working all over the world, they are standardized by their board of the World Institute of Pain Board of Examination. So how to appear for FIPP? So any one of you are interested in clearing the FIPP and CIPS? No. Okay. So should we discuss this topic? Because these are the examinations most physicians take to progress their career practically. So if you are not interested at this point for FIPP, I will not get into the detail.
So can you please tell me details?
Okay. I'm just telling that FIPP, you can go to the wordinstituteofpain.com and from there you can apply for it. Nowadays, previously in our time, the examination was an offline exam. So the application was also offline, but nowadays, at least the some part, that is the application part, you can do online. You will require two things. One, two recommendations from FIPP past physicians. And number two, you will require you to show that you are practicing pain for more than a year. That is the minimal requirement, and more than 50% of your practice should be in chronic pain. That is what is the requirement. Along with, you should have an highest degree of medicine at your country. Like in India, it is the MD that should be the minimal requirement. That is after MD, you can appear for the FIPP. Now, the exam has mainly two parts. One is the theoretical part and one is the practical part. In the theoretical part, there will be 100 MCQ questions and you have to answer all the questions. In the practical part, again, it has two portions. One is the Viva. There you have to clear two cases. Usually, there is no long case or short case. Two cases will be having the equal importance and you have to clear both of them. That means you have to, the case scenarios will be given and they will ask question on that case scenarios. That means they will be asking questions. Suppose they have given a radiculopathy case scenario in a card, case history of the patient, and they will be asking on the radiculopathy. Now, usually the question pattern is the same. That means how to diagnose, what are the investigations, how to manage, what are the pre-procedure instructions, what are the post-procedure instructions. So most of the fiber goes on this. So your first job is identifying the case properly and then answering the questions. So that is how you can clear the fiber portion. But the practical portion, there are for 20 procedures listed, among which there are 4 regions. Each region, there are 5 listed procedures. So they will ask you to do one procedure from each region. So altogether, you have to show them 4 procedures. You have to do it on the cadaver. And in this part, the most important part is the safety. That means they will see whether you are able to perform those 4 procedures safely to the patient or not. So you have to be very, very careful regarding this and don't do anything that is dangerous or detrimental for the patient. So by that way, once they will not ask any question in this part. Okay. Only after your final needle position, they will ask you. whether this is your final position or not, but they will just observe you what you are doing throughout the procedure, and depending on them, they will be given score. And finally, after 1 month of the exam, they will send you the results. Either you have passed or failed. Okay. So that is how you can pass the FIPP as well. Now, in your course, 2 portions we have skipped. So I'll be covering those 2 now. Okay. I've just called the volunteer. The volunteer is present. So one is the ultrasound guided sacroiliac joint block, and another is the ultrasound guided caudal epidural. So anyone noticed that these 2 portions we have not covered yet in other classes? Because in your batch, the day we have shown you the ultrasound guided sympathetic blocks, we are supposed to show on that day only, but we do not have time that day. So we will be covering it today. Sacroiliac. Okay. Ultrasound guided caudal epidural and sacroiliac joint. So let's start that part. Okay. So first of all, why ultrasound? Caudal epidural, you can give blind, you can give with the fluoroscopy, but why ultrasound? The answer is because the convenience. Remember, ultrasound is not the safest, but it is the most convenient. Because with ultrasound, you can do it in the setup where you require almost nothing. You can do it in the ward. That is the advantage. It is real time, it is safe. So because of these reasons, we choose ultrasound over fluoroscopy. And in sacroiliac joint, there are no major vessels. That is one of the biggest advantage. In all other areas, there are big vessels from where actually you cannot go. There are discs. And when it comes to a vessel or behind a bone, if you are not able to see those vessels under ultrasound, then the contrast media gives you a big advantage, because if you are seeing under contrast, then you can actually see how this contrast is spreading. So you are sure that you are not in a vessel. But with ultrasound, that is one disadvantage, that we cannot see anything under the bone and we cannot see the vessels. That is whether I am inside the vessel or not. With the arthrogram, we can, or joint dye injection, we can check whether you are in the vessel or not. So that is a disadvantage of using ultrasound, but all convenient is the ultrasound one. Okay. Coming to the caudal epidural, so to do a ultrasound guided caudal epidural steroid injection, we have to go to the sacral hiatus and we have to find out the sacral cornua. So these are the sacral cornules. Okay. And in between this U-shaped structure is the sacral hiatus. I don't have to do or say much about this because we all know this part from the anesthesia knowledge. So here our aim is to put the needle inside, but there is a big difference. When we are giving the fluoroscopy, we usually go at the level of the lower border of the S2. But when we are giving the ultrasound guided caudal epidural steroid injection, then you should remember one thing, that if you go that high, you will not be having any guide to check whether you are inside the vessel or you are outside the vessel, that you do not have any guide on that part. So in this regard, in ultrasound, we have to give it just after crossing the sacral hiatus, so that there are less chance of going the needle inside a vessel. So that's a big difference. Initially, there was a technique that is known as the hybrid technique. The needle is inserted under the vision of the ultrasound, but needle is progressed with fluoroscopy. But here, when we are doing that thing, you require a fluoroscope. The convenience of ultrasound is lost. So nowadays, it has been found, there are studies you will find in the PubMed, but they have actually, nowadays we follow that study only. We just cross the sacroiliac joint and give the drug there, because in that way we are avoiding going into the much interior side and avoiding puncturing into the intrathecal area, nerve root, and other places. That is how we can do it under ultrasound. So what will be our guide? Our guide will be this sacral cornus. And what is the advice? The ultrasound is advantageous because when we are giving it with the help of ultrasound, the big advantage comes that when we are doing under ultrasound, we have a line. That means our ultrasound is in a linear fashion. That means if you are putting the probe like this, Okay. Now, if you put the needle within in plane, so there are no chances that you will be going lateral to the cornu. Will be always be inside the cornu when you are seeing this portion. So that is the big advantage of the ultrasound. Whereas when you are going through the fluoroscope, sometimes you might go left or right, or sometimes you might go superficial. As everything in the ultrasound is happening in the same plane, so getting lost from the plane is almost impossible. So the chances of needle introduction is comparatively easier with ultrasound. Whereas the needle behind the bone is better seen with the fluoroscopy. So you have to put the probe like this, and then you have to enter in between these two sacral corners. And here in this picture, we have moved up and we are seeing the posterior table here. We are seeing the posterior table here. And in this part, we are not able to see the lower portion because the lower portion, the posterior part of the S4 and S5 vertebral body are not visible at this point. But when we are coming down at this portion, we are able to see this posterior part of the S4 and S5 sacral vertebral body. So in that way, we have to go at this portion. Now, once we have reached this portion in between the cornus, then we'll rotate the probe 90 degrees so that we can see this picture. That means at up to this point, there is the bony covering of the S3, S3 spine, and then there is a gap, and that is the sacral hiatus. And this line you can see, this is the sacrococcygeal ligament. So basically, here lies the sacrococcygeal ligament. So our job is to take the needle, and with the needle we have to actually cross this sacrococcygeal ligament. I usually under this view we take the needle from lower side, and here after crossing the sacrococcygeal ligament we have to start the probe. That means we have to start the Doppler, color Doppler, so that we can see whether the drugs are coming to the outside or drugs are going inside. That much we can see. But unlike the fluoroscopy, where we can actually see the inverted fat tray appearance, and by which we can confirm needle position, that provision is not here. But once you have crossed the sacrococcygeal ligament and the drug is going inside and above, then we are sure it is going to the that area. Okay, that much we can establish with the help of the ultrasound. So this is the picture. So you have to first give a local anesthetic in the skin and subcutaneous tissue, and then you have to put the epidural needle. So here we are putting the epidural needle, and this epidural needle will enter crossing this sacrococcygeal ligament to inside. And once you are inside, this is where it is crossing the sacrococcygeal ligament, and then either you have to give the drug here, or if you're using a hybrid technique, you can put the needle up to the lower level of the S2 with the view that we are seeing under fluoroscope. And once you reach your area, you can give the dye, and with the dye you can confirm, and then you can give the drug. So ultimately you can inject steroid through this way. So this is an alternative method of injecting steroid. So you can see in this video how it is being done. So local anesthetic initially given, then this is the needle progression. Needle is crossing. Okay. Now here hybrid technique is used, that is done under fluoroscopy. So in that case, you can put the needle up. Okay. And then after checking, we can give the injection. Similarly, sacroiliac joint injection, it is also very safe to give even if we do it with the ultrasound. Okay. Because in the sacroiliac joint, we are having no important or major vessel. Right? It is easy to access. It is comparatively superficial as well. So ultrasound guided sacroiliac joint injection is very common nowadays. Even in my clinic, I mostly do it under ultrasound patterns because number one, it is convenient. It's easy and the results are also excellent. So we all know regarding the anatomy, it's a diarthroidal radial joint, the articular surface of the sacrum and ilium, which is separated by the joint space. They are enclosed within the fibrous capsule. So ultimately, we have to go inside this fibrous capsule. And this joint is like having the synovial joint characteristics, especially in the posterior and the inferior portion of the joint. And that is where we inject the local anesthetic steroid. And the superior posterior joint surface lacks the joint capsule and housing the interosseous ligaments. Okay, so joint capsule are actually covering from the different side. One is the joint capsule, then there are some ligaments that is actually reinforcing this joint, like the anterior sacroiliac ligament, posterior sacroiliac ligament, sacrotuberous, sacrospinous ligament. And definitely there are age-related degenerative changes that is possible in the synovial cleft, which is inferiorly, and which might lead to the fibrous ankylosis. So this is how the sacroiliac joint is actually reinforced. Like anteriorly, we have the anterior sacroiliac ligaments, but definitely in this area we cannot go because it is inside pelvis. We have to enter from the posterior area. Posteriorly, we have the sacrotuberous and the sacrospinous ligaments, and these are the posterior sacroiliac ligaments. Then we have this sacrotuberous ligament, and we have this sacrospinous ligaments. All are actually increasing the stability of the sacroiliac joint. Now, while we are going inside the sacroiliac joint, it is very important that the sacroiliac joint is exactly lies just behind the posterior superior iliac spine. Okay, so as a landmark, posterior superior iliac spine, this area is a very important landmark. So we have to first palpate the posterior superior iliac spine. Then from that area, we can start scanning downwards. And here, usually, we found this structure when we look at this point. So here it is the ilium. You can see the ilium. Then we have the sacroiliac joint. And just behind, just inferior to this posterior superior iliac spine, we have the S2 foramina. So it will be the bony margin will be like this. In the laterally, we will be having the ilium. Then we will be having the sacroiliac joint. Then we will be having some portion of the sacrum, which is lateral to the sacrum, lateral to the foramina. So this portion exactly, this portion will be there. And after that, there will be the sacral foramina through which the echoes will move down. So that echoes will move down to two areas. One is this area and one is this area. That means echoes in from the bone will be reflected here. So there will be hyperechoic shadow in all those areas. But at two areas, the echoes will be going inside. One is the inside the sacroiliac joint and one inside the sacral foramina. So these are the two areas through which the echoes will go. Then we'll be having the posterior portion of the sacrum, and then we'll be having the this portion is actually the spine. So we'll be having all these areas as a bony margin. So you have to identify this bony margin. Remember, someone asks this question that getting the S2 foramina is essential. S2 foramina is essential for identifying the anatomy, but getting the S2 foramina at the time of injection is not necessary. But you should know where the S2 foramina is. You should examine this portion and then you should do the procedure. Next comes to the muscle coverings. So what are the muscle coverings we have? We have three muscles here. In the lateral and superficial part, we have the iliocostalis. Lateral and the medial part, we are having the longissimus. And below and medially, we have having the multifidus. So iliocostalis, longissimus, and multifidus. These are the three muscles. They cover below the skin and subcutaneous tissue at the level of the sacroiliac joint. Now, as we move next, we'll be able to see the indications. So again, indications are of two types. One is the therapeutic, another is the diagnostic. The diagnostic to establish sacroiliac joint as a pain generator, and therapeutic for the treatment of the sacroiliac joint pain or the sacroiliitis. It may be secondary to some other disorders like a trauma. Okay, it can be secondary to trauma. It is possible to be secondary to a disorder like spondyloarthropathy, even though for the management of pain, the injection inside the joint, it is possible. These are more common in the patient with the injuries in the limbs. That's why there are unequal pressure in the legs, and ultimately they are giving to a secondary sacroiliitis. Or sometimes if there is a limb length discrepancy, these patients are also prone to develop the sacroiliac joint pain. Among the contraindications, first of all, the patient's refusal and patient is allergic to any of the injecting medications. They are also contraindication. And if there is local malignancy, that is also a contraindication for just giving steroid injection. We have done this procedure of sacroiliac joint denervation in case of malignancies as well, that we can do with the help of the cryo or cooled radiofrequency, and that is also possible. But in all other areas, usually these are the contraindications. And relative contraindications include the coagulopathy, pregnancy, systemic infection, diabetes type 2. So these are all relative contraindications. Yes, any questions? Someone is asking anything? No. Okay. Next, advantages of the ultrasound guided sacroiliac joint injection. Obviously, it is easy and soft tissue structures can be visualized better. It can be performed at the bedside, and USG does not expose the patient for the ionizing radiation, which is not possible in the X-ray. And there are some limitations like periarticular injection risk is there. Contrast agent arthrography is not possible with the help of ultrasound. And the intravascular injection detection, which is possible with the help of the fluoroscopy, is not possible with the ultrasound. So these are two limitations that we found in case of quadrilateral epidural as well, in case of sacroiliac joint as well. But in sacroiliac joint, as there are no major vessels and the chances of the intravascular injection is comparatively less, that's why we prefer doing sacroiliac joint injection under ultrasound. This is how the picture will look. So as you see, there are the two areas where the echo is entering much more. Okay, so what are those areas? One is this area. So what is this area? Can anyone tell? At this area, echoes are entering much. So what is this area? This is the sacroiliac joint. And what is this area? Can anyone tell?
Sacral foramen, sir.
Hmm, this is the S2 foramen. So in these two areas, echo will enter. If you want to inject for the sacroiliac joint injection, your needle should be coming like this. Okay, usually from medial to lateral side. Why medial to the lateral side? Because lateral side there is the iliac covering. So bypassing and going through this iliac covering is difficult. So preferred is medial to lateral side. We go and then inject. Okay. Next, you can see already these are the marks. These are the sacral foramina, sacrum, portion of the sacrum lateral to the sacral foramina, sacroiliac joint, and this is the iliac bone. So ultimately, we have to target this sacroiliac joint area, and you have to put the needle like this, and then you can complete the procedure. So in the last, I will be just showing it in the volunteer with the ultrasound. Just 1 minute as I'm alone. So I have to take 1 2 minutes to see the these things. Okay, I have to touch all everything. Just give me 1 minute. I'm coming back.
engage ଅଛି ନାଇଁ
That's okay. I'm coming back. Okay, I'm just arranging the things. It is almost done. Hello, am I audible now?
Yes, sir.
Okay, fine. So, okay. Can you see the patient now? Hello?
Yes, sir.
Okay, fine. So let's start. So we are having the volunteer. So we'll be trying to see at the level of the sacroiliac joint. So for the sacroiliac joint, definitely we'll prefer taking the curvilinear, but all depends on the depth. So if the depth is low, you can take a linear probe as well. But, inside the, as it is a diverging beam which happens in the curvilinear probe, so it is easy to get the diverging beam inside the sacroiliac joint if you are taking the divergent beam. So I will start scanning from the posterior superior iliac spine. So I will first palpate the PSIS, then I will put the probe in such a way that the index marker is in the towards the lateral side. So okay. So here at this point, you can see the spine. That is very important. I'm just decreasing the depth. Okay. So at this point, we are able to see the portion of the sacrum and the portion of the iliac and close to the posterior superior iliac spine. So can you identify the areas? Which one is close to the spine and which one is the PSIS? Let me stop, freeze and show. So here we are not seeing much inside, but at this portion, we can see the spine. Okay. And this is the posterior superior iliac spine. So we have reached that area. Now we will move slightly towards the caudal side. Okay. So from that area, we'll move slightly towards the caudal side. So as we are going towards the caudal side, you see, There are some changes. Okay. So here, the image what you can see of the posterior superior iliac spine, here it is coming down, and you see there are two areas to which the echoes are going in. See, now at one area echoes are going directly inside. So this is basically this is these two phenomena. And another echo, you can see I am stopping at this area because this is a very good area to stop for you to show. See, now you are able to see that two areas the echoes are going in. One here along this direction and one along this direction. Okay? So this is the portion of the sacrum. This right side is the portion of the sacrum. And here two echoes are going, and this is the SI joint, and this is the this two foramina. Our target is the SI joint. If you have to perform the procedure, then we have to go from medial to lateral side. And among the muscles, here at the lateral side, we have the iliocostalis. And you see, I do not know whether you can see my cursor or not. Can you see my cursor? Can you see my cursor?
Yes, sir.
Okay.
Yes.
So here at this portion, we are having the iliocostalis. In this portion, we are having the multifidus. And above, we are having the latissimus dorsi. So these are the three muscles. They are sometimes possible if you can look it closer, them separately, but it's not important because we are not going to that areas, but we are actually going towards the sacroiliac joint. I am again repeating, so how you can get it very easily. It is very easy to get the sacroiliac joint. You don't have to do much. You just try to. Again, I am showing you. Okay, just see. First, I am palpating the posterior superior iliac spine. This portion is the posterior superior iliac spine. Let us first put the probe on the posterior superior iliac spine. I am diffusing. Okay, you can see the posterior superior iliac spine. And as I am slightly coming down, you can see at two areas, you can see the echoes going in. One is the, okay, one is the S2 and other is the sacroiliac joint. So once, usually at this point, when you can see the sacroiliac joint clearly, it is not necessary to get this S2 foramina clearly. But once you can see the sacroiliac joint, the opening of the sacroiliac joint clearly, this is a good area at which you can give the sacroiliac joint injection. Okay? So what happens? Initially, the lateral portion is comparatively higher because of the ilium. Now, at the lower portion of the ilium, you can see the lateral portion is coming almost at a equal level. Okay? It will not be such higher. At the posterior superior iliac spine, definitely it is much higher. As we go down, it comes almost at the equal level. Here it is the S2, and you can come slightly down. Here at this is the S2 portion. And we can come slightly down as well. So at this portion, there is no S2 foramen. Here we can get a clear sacroiliac joint opening. Okay. So here we are having only one opening. This is the clear cut sacroiliac joint opening. Okay. Let me draw. This is the sacroiliac joint opening. No, this is the wrong thing. Here you can see this is the sacroiliac joint opening. Here we can put the needle inside. And there is a feeling of cutting the capsules. And once we are inside, then if you're doing a hybrid technique, we can use the check the arthrogram. But if you are not using, you can simply inject the local anesthetic and steroid there and come out. So it is simple. It is very effective. Most important thing, it is not being simplicity, but effectiveness is also very important. At this area, it is simple as well as effective. So how many times you have to give? Usually, for the chronic sacroiliitis, sometimes you might have to inject 3 times. If even then the patient is not responding, then you can go for the radiofrequency ablation of the sacroiliac joint, okay, the sacroiliac joint denervation. But in most of the patients, even for the chronic sacroiliac joint pain, usually 1 or 2 injection of the local anesthetic steroid is having the highest evidence in sacroiliitis of the sacroiliac joint pain. So that is how we treat sacroiliitis. And remember, in this regard, ultrasound is almost replaced the fluoroscopy. Not in all areas, but at least in this area, it has almost replaced the fluoroscopy. Let's go a little down with the caudal epidural. Everything remaining the same, I'm just defreezing and scanning below from that area. Okay, let us defreeze and start scanning below from that area. So here you can see we are at the center. Center there is spine. In both sides there you can see those are superior iliac spines. Now as we are going down, now you can see the S2 in both the sides. Okay, I'm just continuing with the same. Okay, so S2 foramina, then continue. Okay, then S3 is coming. As we are further down, now see, this spine height is reducing as we are going further down. Okay. Now see, once we are crossing S3, this spine is being splitted. So there is no covering. Okay. Posterior portion is now open. Okay. When I was above, the echoes are not entering in the posteriorly inside. But as I am coming down, now echoes are going in. And you can see both the sacral corners. Okay. I'm just showing it clearly. You can see both the sacral corners, left and right corner. Let us do one thing for you. Let us decrease the depth so that you can see the corners better. Okay. So we can see both the corners here. And that is the area where we have to perform the procedure. So what we need to do, we have to keep it at the center, and now we have to rotate the probe 90 degrees. Okay. Once we have rotated the probe 90 degrees, we can see this picture. Okay. So put it at the center and we are freezing. Okay. So at this point, you can see this is the sacrococcygeal ligament that we are able to see. Now, this part is very easy for the anesthesiologist who are practicing regularly. This part is very, very easy. So you can see this sacrococcygeal ligament. So the drawing is not correct entirely. Let's delete and redraw. So this is the sacrococcygeal ligament. That is how it is going. So what is our needle probably coming? We'll be giving local anesthesia below, and then we'll be just entering like this, and we'll be putting our needle like this. And once we have crossed, we have injected there. Remember, that is the difference with the fluoroscopy, but we should not go much inside. So I'm showing you the same thing with the help of a longitudinal probe now, because this podia is superficial, and here we can use both. We can use both the curvilinear and the linear probe. As the depth is low, so linear is good enough. So I'm showing the same thing with the linear probe. Okay. So let me change the probe. So I am showing at the level of the, again I am keeping the index towards the left side. And here we just try to see that these are the two sacral corners. This is clear to everybody? Two sacral corners we can see. And inside we can see the posterior portion of the sacrococcygeal ligament in cross section. You see here, this is the left sacral corner. This is the left sacral corner, and this is the right sacral corner. And here in between, we are having this ligament. Okay. So we are having, this is the sacrococcygeal ligament. So this ligament we need to pierce, but not in this view, because we have to come from below. So once we get this picture, then we rotate our probe. So let's see. Once we got this picture, okay, I'm again defreezing, showing in the patient. So once we got this open corner, then we have to rotate. So keeping in the midline, we rotate our probe and we'll see this portion. Okay. So this is the exact area. This is one cornu that is one towards lateral side, and in opposite side we'll reach to another cornu. So this is another one cornu. You can see this is the cornu of the right side when I am tilting the superior part towards the right side, and this is another cornu. It is of the left side when we are tilting towards the left side. So we have to keep in between, and this is our target entry point. Okay, so see, up to this portion, it is the reflective portion. You can see this is much hyperechoic up to this portion. Okay. So up to this portion, it is very much hyperechoic. So it is the bony portion. Okay. And after this, what I am drawing in yellow is basically the area where we have to. This is the sacrococcygeal ligament. Clear? This is the sacrococcygeal ligament, which I am covered with the yellow line. Ultimately, we should need put our needle in from this way, like from below. First, we will give local anesthetic here. With our needle should come and pierce this. And then we have to inject the local anesthetic and steroid. And usually 10 to 15 ml local anesthetic steroid is given because here we give mostly for the L45 and L5S1 group. And for that much volume is usually good enough. So any questions regarding this area, this sacroiliac joint injection?
To diagnosis of sacroiliac arthropathy, what investigation will advise for X-ray or MRI?
Okay. Regarding X-ray, X-ray is having a very poor value. Okay. So if you are diagnosing with the help of the X-ray, the diagnostic efficacy of the X-ray is very, very poor. Unless and until it's a very old or chronic sacroiliitis, the changes do not appear in the X-ray. But in MRI, you can get a white area. Okay, that means hyperechoic, not hyperechoic, but it is an intitulated image. Water looks white. So when there is inflammation in the SI joint, what happens? One-sided SI joint, it will appear white. And then the other changes, even the chronic sacroiliitis, will be possible to check with the MRI. Okay, margin irregularity and other changes that you can see only on the MRI. So to detect the sacroiliitis, best diagnostic investigation is definitely the MRI, not the ultrasound.
Sir, whether if we can use ozone apart from steroids,
Ozone is another modality that is explored in past. Okay, now still it is sometimes used as a prolotherapeutic agent. But the problem with the ozone is that there are clinical evidence. Okay, so what is the current evidence? In last, it is published in 2013, and that is done by Manchikanti et al. And there they have shown that the peripheral ozone around the disc is having a good value in case of radiculopathy. That's why it is used to the peripheral ozone injection. But what they have shown, the intradiscal ozone injection is only having the plus 2C plus value. So it is actually not very good. So ozone is good for the disc, but for other areas, still the number of studies are not enough. So if you see the evidence that is published by the WIP, that shows that for the sacroiliac joint pain, the best evidence, I think it is 2B plus. That is with the steroid only. Okay. Even it is better than the radio frequency ablation or the denervation. That is why, as a preferred mode of treatment, we prefer the sacroiliac joint in steroid injection and mostly the particulate steroid injection.
Thank you, sir.
Okay. Any other question?
Sir, when we should opt for caudal epidural or epidural steroid, sir?
Okay. The biggest indication for the epidural steroid injection is the radiculopathy. Remember, in radiculopathy, if there are no red flag signs, there is no contraindication of giving an epidural steroid injection. Only in case of red flag signs, it is urgent to go for a surgery. Then rest all the patients can be managed conservatively with the caudal epidural steroid or the transforaminal epidural steroid injection. Now, regarding which procedure to opt for, whether it's the caudal epidural or transforaminal epidural or the epidural that is intralaminar epidural, which is the choice? Remember, in the higher areas, like it is the L2, L3, L4. Okay. In those areas, we prefer giving the transforaminal. Even for the L4-5 and L5S1, we prefer giving the transforaminal. Caudal epidural is almost an alternative of the transforaminal at the lower areas, and the evidence of the intralaminar epidural comes least. The reason behind is that the transforaminal epidural gives you the advantage of putting the drug in the anterior epidural space. And the anterior epidural space is the area where the most of the inflammatory mediators, the disc products that happens. That is why nowadays transforaminal comes first, then it is the caudal for the lower areas, and then it is the intralaminar. And regarding the caudal and intralaminar, it is very difficult to predict which is better because number of studies regarding caudal is the more, and that is why the only reason behind the caudal epidural being a little bit above in evidence than that intralaminar epidural. Otherwise, if you see the intralaminar epidural, that is also good enough. So it is not bad.
Volume
Sir, is it advisable to okay? Sir, is it advisable to give caudal epidural for lumbar canal stenosis of any level?
Yes. See, lumbar canal stenosis, epidural steroids are indicated, but only problem with the lumbar canal stenosis compared to the radiculopathy is that effect is not very long lasting. In radiculopathy, you can expect a very long pain relief, where in other cases, you might not expect the similar pain relief. In fact, in canal stenosis, if you give the epidural steroid injection, then there will be relief for certain period, but usually after 2-3 months, or sometimes after 1 month, the pain comes back. That is one of the biggest problem with the epidural in the canal stenosis. So in those cases, you can simply go for the foraminectomies. Okay.
Thank you. Thank you.
So this is the last class. So any other question?
Sir, how long is the content available online for revision?
Okay. See, this lecture, what we'll get in the app, that is actually up to the exam, it will be there. But after that, we have to clear it because we do not have unlimited cloud. So ultimately, we have to clear the cloud for the next batch. Okay. Previously, we used to keep all recordings for up to 7 days, but now we have increased till the end of the course. We do not delete, but it is not that we can continue for long. So up to next 2 weeks, it will be there. After that, the study materials will be there as usual because they do not take a large area, but the recordings will be deleted.
Okay, so there any content available on YouTube?
Definitely go to our channel. There are a lot of free contents there available in our YouTube. Okay, and even in the app also there are some contents that we'll get from the YouTube. Okay,
Okay, thank you, sir.
even you will get some free content from here also because the classes are very large. The YouTube contents are smaller, 5 to 10 minutes content are there. Okay? On different topics they are there. YouTube channel is also there, in our app also there. The same content actually you have put in our cloud already.
Okay, so thank you.
Okay. Now regarding the examination will be online for this course. And usually, depending on the requirement of you, either we can take this weekend, that means 26th, 27th, or not 27th, sorry, 27th, 28th, or 4th to 5th. So which one you prefer? If you want to study for a week and then give the exam at 4th, 5th, usually we do it in the weekend. Or you want it in the 27th and 28th.
The 4th and 5th.
Okay.
Fourth
Then
and
we
fifth.
can schedule I will be scheduling your final exam on 4th and 5th. Okay. And the instructions in detail I will be posting in the group as well as the application.
I just have one question concerning the exam. Is it on a precise time or I can do it during the weekend?
Within 48 hours, you can do it anytime.
Okay. Okay, thank you.
Any other questions? So it is 4th, 5th, remember?
So is there any workshop planned for our course?
See, not specific for the course. We do not plan the workshop just at the end of the course. But time to time, like in just previous month, we have had one workshop. So similar workshop will be announced. Okay? Because we are doing multiple batches And then we are having this workshop as well as we are having some offline courses of 7 days as well. It is also announced.
So
So the
we
study,
can get
sir, study material and the videos in the app, it remains, no, sir? For
Videos, I have just told you, the videos takes a huge volume. Okay, these are large classes, 2 hours, 2.5 hours. So we will not be able to keep the video. We have to clear it. After 15 days, we have to clean it. But the study materials will remain forever. The forever means as long as Asian Pen Academy is there, and hopefully it will not end.
okay, thank you, sir.
Any other questions? Your batch, all the study materials that will remain.
sir, in India, we can get any practical pain fellowships where we can do
Okay.
practical
Okay, the practical pain fellowships, if you are asking,
other than FNB and DM, other than FNB. and DM.
see, if you are asking for a course, and what I will prefer is definitely the DM, that is the best course, and next is the FNB. There is no doubt regarding this. But they are long time. Only problem is you have to spend 2 years time or 2 to 3 years time for those. If you don't have the time, we have the ISSP courses, that is 1 year course. Okay. Or you can attend the small workshops like we do, 7 day workshop. So that we can do. So basically, remember the legal portion is not a problem because if you are done the anesthesiology, then by virtue of your being in anesthesiology degree, you can do almost all the point procedures. It is there. But if you want to go further or if you have to learn more, then you will need these courses. Okay. And you are always welcome in our short-term courses. Okay. Now it's the time I will ask how you liked the course. Just switch on your camera and please give your opinion regarding this. Okay. I'll just request you everybody, please switch on the camera and you just say something about the course. Please, one by one.
Yes, I would like to say that I liked a lot this course. It gave me a new horizon for as an anesthetist. There were some things I always apprehended to do, but now I see that I'm more encouraged to begin to do this. I know that it will take some time. I still need some practice. I still need some knowledge, of course, but I am very encouraged to begin my career as a pain anesthetist and pain management.
Thank you. Dr. Ramya, you are also in the camera. That's why I'm asking you as well.
Sir, honestly speaking, for a basic course, this was really, really very good. Most of us, we are not into the pain management area. For us, it was really, really very helpful. There was one thing that I wanted to ask, sir, regarding the advanced course which you have. I think it is already started on the 16th or 14th of April already.
Yes.
Is there any other batch that is starting off after we give our exams or anything like that?
Uh,
So,
after 2 months, we'll announce it. Usually, we announce after 1 week after starting the course. So
okay,
within next week, we'll announce the next one.
okay, sir. But overall, yes, sir, I'm wanting to go for the advanced course. Means that I'm actually like the basic course a lot. It was really very helpful in attending.
Thank you. And another thing is very important. We'll be happy if you start pain practice. That is what is
Yes,
our aim.
sir.
Okay.
Yes, yes.
So because we are as a number now, we are increased. 2010 there was only few, one in every city, but now at least 5 to 10 is there. But remember, if you see the number of orthopedicians or gynecologists, so we are no extreme number. So we have to
True, sir.
increase ourselves, and it is a very good avenue, especially for the anesthesiologists. It is a very good area to explore because here you have your own patients. That is the biggest advantage.
Yes, sir. Yes.
Dr. Anushri?
Sir, basically, I didn't have much, any exposure regarding pain. So this helped me actually to know at least what exactly pain medicine is. Though we had heard about it, I got to know so many practical things. But now I'm feeling basic is only a bit of it. So need to go for advanced also. And ultrasound, I have got much idea, sir. But regarding fluoroscopy and CM guided, I don't feel like maybe workshops need to attend to get
Yes,
more
yes,
this.
because two areas are there. One is the theoretical part, then practical part you are showing, but now you have to practice by your own hand. And that is also very important.
Okay. Or else I'm very happy with the basic this whatever this compared to first day, and now at least I'm more confident if any at least procedure ultrasound guided any procedures to be done. I think I'm confident to do.
Anyone from the others who want to say anything?
Sir, I want to request that kindly conduct a radio frequency ablation workshop offline or online. Maybe.
Okay. Actually, we will be starting a 7-day course in which we are offline course where we will be covering the radio frequency ablation in detail, because here if you are not seeing the machine, sometimes it becomes a little bit difficult. Though I have demonstrated in a video, but definitely if you come in the offline, I think we can discuss much more with the radio frequency. Okay. Because doing a course only with the radio frequency sometimes becomes difficult. It may not be a long course. Okay.
Yes, sir.
So where will the radio frequency course be conducted, sir?
It is not a only radio frequency course. We are arranging from June onwards. Already it is in our website. So from June onwards, we are starting a 7-day offline course.
Okay, sir.
Okay. And there we will be discussing all the topics. Especially, you have just now you have seen the things, but you have not done on the volunteer, or not done in the mannequin. So here we have the mannequin, not in ultrasound. Ultrasound mannequins are not possible. Actually, the technology is not much developed. Even the ultrasound, what GE gives the mannequin, they're very poor quality and they're nowhere close to real. At least our fluoroscopy mannequin is very good, and there you can practice, and that gives you the real life feel. And in fact, the fluoroscopy you learn in mannequin better than cadaver. Okay, so let's say bye bye for today.
Thank you, sir.
Thank you.
Welcome.
Thank
Welcome
you, sir.
everybody. Let's end the course today. The class and the course. Unfortunately, today 3 people of us are actually very busy. That's why only me came today. But otherwise, in the end, usually all 3 are together in most of the courses. Anyway, let's. So my only thing is request to you, start your pain practice. That is the most important thing. Okay. And you will enjoy. With time, initially you might having a little bit struggle in getting the patient. With time, everything becomes easy. Thank you all. Let's end today.